Well, good morning, good afternoon, good evening, wherever you are in the world. My name is Ethel Richards, and I am the Plant Based Nutritionista. And this is our podcast where we build a community in health, welcoming you into my virtual kitchen wherever you may be. We talk about all things health and wellness, guys, not just nutritional health, even though that's near and dear to my heart. We talk about financial health, mental health, spiritual health, financial health, you name it, we talk about it because your health and wellness is complex and decisions that go into that are equally complex, sometimes if not more. So today I'm so excited to bring this conversation to you. We're going to be talking about the power of population health. What is population health? Have you even ever heard of population health? And I have the guru, and I can say this because I have followed this young man throughout his career. Dr. Steve Spencer is here today, and I think he's one of the best population health leaders, got on the train early, just out there doing great things, not just in Philadelphia, but I'm going to just say kind of up and down that East Coast corridor a little bit. So welcome, Dr. Steve Spencer, to the podcast. Thank you so much for being here today. How are you?
I am doing great. So great to be here.
Thank you. Thank you. Well, we are glad to have you. So I thought it would be great to let people actually hear from you a little bit about who you are, your backstory, and how you fell into population health, if you will. And then we can go from there.
That sounds wonderful. So I'm gonna start with where I'm at now. So I am currently the Deputy Chief Health Officer for City Block Health. And City Block Health is an organization that started in 2017, started as a tech startup. And its mission is to radically improve the health of marginalized communities at scale. And it really grew out of this idea that we wanted to provide the same level of healthcare for patients on Medicaid, most of which are underserved, marginalized communities, that folks with high cost commercial insurance are able to access. And so it started out with some venture capitalist money, started out with some amazing designers and strategists and experts in their fields. And they decided they would partner with Medicaid programs to provide full service wraparound services for Medicaid patients in order to improve health outcomes. I have been here for about 6 months. Amazing group of people, amazing organization, and I lead the population health team, which is composed of our clinical subject matter experts in many different fields. So I'm going to start with that. So park that for 1 second, and then I'll sort of take you to the beginning. And whenever I tell this story, I always say I can give you the 5-minute version, or I can give you the 2-hour version. I'm going to land somewhere in between with the story, and I think it's an interesting story because I think it does allow us to go on a journey and figure out sort of how I got to this place. So I grew up in Philadelphia. I grew up in the Grays Ferry section of Philadelphia, which is a very underserved community, very poor community. And the story I always like to tell is I went to a Philadelphia public school in my neighborhood, and it was an underperforming public school. And I was not a star student. I was an average student in this underperforming public school. And if you had said who were going to be the successful people in this school, I would have not been picked. I was the person right in the middle. And it was only by really sheer luck. My grandmother had found out about this private boarding school called Girard College. And she told my mother, she said, I think you should think about signing him up for that school. And so she did, and took the test and went to the school. And at the time, I'm in second grade. And so when most people hear that story, they're like, what? You were thinking about going to private boarding school in second grade? But for me, I kind of had this strange insight, although I wasn't the best student at the time. I kind of realized, I was like, I think this is a unique opportunity. I'm 7. But I think this is a unique opportunity, and I think this could be life-changing. And I also thought of it as a 7-year-old would, as this ability to leave my environment. And then it almost felt like I was going away to camp. So I sort of saw this excitement in that respect. So I got into the school. I started the school in 3rd grade, September 17th, 1984. And I won't say that there weren't struggles in the beginning. I think when you take any child that's young out of their natural environment and put them into this environment that's not so familiar, there were some struggles. But the saving grace was actually the first marking period when average student now gets straight A's. And so the positive reinforcement from that was amazing. I had never experienced anything like that before. And then I was off to the races. I was like, I love this. People were giving me attention. So did really well in elementary school. And then when I got into middle school, I started thinking about what I wanted to do for a career. Um, and then I thought, I want to be a doctor. I want to be a lawyer. And that's because, those are very prestigious professions. They're academically challenging professions, and they help people. I will tell you that the reason I chose to be a doctor was because they have less paperwork. I realized later on that is not true, but at the time, that's what I thought. And I also like the idea of the lifelong learning in medicine. And of course, I like the idea of helping people. And I also like the idea that in this underserved, marginalized community that I came from, I could already see the ramifications of poor healthcare and how that affected people. So then in high school, I started talking to one of my classmates, and her uncle was a health administrator, and he worked at one of the local hospitals. And she told me what he did, and I was just fascinated by it. I said, wait a minute, not only could I have this effect on people at a one-on-one level clinically, but I could have an effect on a large group of people and really affect their healthcare and their outcomes. I said, I'm in. As I said, I knew at that point I wanted to go to medical school, I wanted to be a doctor, but eventually I wanted to be a healthcare administrator because I wanted to have this large population effect. And so I ended up going to Brown University for college and medical school. And in between my third and fourth year in medical school, I decided to get my master's in public health from Harvard. And I made that decision. I actually started thinking early on that I would probably get a master's in business administration. But I made that decision because I started to think more about sort of the social aspects of healthcare. And I wanted to combine those things. So the public health degree gave me sort of epidemiology and biostats, but I also focused in healthcare management. So I did finance and management and marketing as well. Again, an amazing experience, amazing people that I met, and I'm so glad that I did that. So I came back, I actually spent 6 weeks in Kenya as well, which was amazing, and sort of got my clinical juices revving again. And I said I wanted to come back to Philadelphia to practice for various reasons, including, wanting to be close to family and friends, but also I knew that there was a need in Philadelphia. And chose Temple University because it was in the heart of North Philadelphia, one of the most underserved areas in the city. And I had a great experience there. It was an amazing training place. It was academically rigorous and challenging. I got to interact with a lot of great people who were happy to see someone like me helping to take care of them. But my level of frustration was around social services. So we had this amazing experience and we gave them this great level of care, and then you send them home and immediately they're back. And it was oftentimes for reasons that you think would be easily taken care of. So for instance, you have congestive heart failure, and one of the reasons you're often admitted to the hospital for congestive heart failure is dietary noncompliance. So you're not eating the right things. And so we tune them up, we get all the fluid off of them, get them on the right medications, blood pressure is good, we send them out, and their first meal is the Chinese store. And so with high sodium foods. And so they're back the next day. And so that was one of my frustrations. And I thought, okay, this is great. I love working with this community. I love this population. But if we don't have the appropriate social services and we don't have the appropriate health literacy and training for these patients, we're never going to get anywhere in terms of actually getting good outcomes. So I decided that I was going to go about 10 miles, literally up the same road to a place called Abington, which was in a more affluent community, but was close to the city. And I spent 15 years there as a primary care doctor and a hospitalist in internal medicine. Again, a great clinical experience. But I did tell them on my first day that I wanted to be a healthcare administrator because, of course, I decided that in high school. And so they said, sure, that sounds great. So 5 years in, I said, okay, I'm ready to be a healthcare administrator. They said, I don't have anything for you. And then I said, okay, well, I'm going to have to start looking elsewhere because that's what I really want to do with the rest of my career. And then about 2 weeks later, they came back to me and they said, we are going to make you the medical director for population health. And I said, well, what does that person do? And they said, we don't know, but we think it's going to be really important in the future. And this becomes a theme in my career that I sort of am the first to do these roles. So it was good. I got to really shape that role. One of the things I did in the beginning before I really started to solidify what I was going to do in that role is I did a lot of community outreach because that was important to me. So I spent a lot of time at churches and local community organizations talking about basics of healthcare around some disease states like diabetes and hypertension and cancer, but also stressing those what we think of fundamental pieces that may seem obvious to other folks, but things like nutrition and things like physical exercise and things that will certainly be those things that will help to improve health outcomes in addition to any of the other services that we're adding clinically. Beyond that, I basically helped to formulate our population health strategy and help to formulate the whole population health infrastructure. And I should take a moment, since I'm using that term, to sort of talk about what is population health. So population health simply really is looking at a large group of people and figuring out what interventions you're going to put into place in order to improve that population's health. It's also looking at the things that determine those health factors. So the environmental factors are, of course, are important. So things like geography are important, but environmental also means the things you're taking into your body, how you're taking care of yourself, where you work, where you live. So taking all those things into account and then creating specific interventions. So we created interventions around behavioral health. We created interventions around pharmacy. We created interventions around care coordination when you're leaving a hospital. Remember, I told you those stories. You leave a hospital and then you all of a sudden have do things at home and you're all of a sudden back. So making sure we wrap around services for when those people who are leaving the hospital or leaving the emergency department. And so we built out that piece. A large part of it is also data analytics. So knowing the health of the population. So again, when Mrs. Jones comes to see me, I have her chart. I know what's going on with Mrs. Jones. I can make a treatment plan based on reviewing her chart. But I also can say my 50,000 patients that are part of my ambulatory network, I can look at my diabetics and see which ones of those are out of control. And then while I'm doing the individual interventions, when they're coming to the office, I'm also doing interventions for the entire population to try to change the outcomes. So that was a wonderful educational ground. I got to do a lot of great things. I was also, in case you want to Google these things, we love acronyms, accountable care organizations. I was associate medical director there. Accountable care organizations are sort of trying to, on a large scale, again, this sort of idea of value-based healthcare, where you're looking at making sure you're increasing the quality of the healthcare delivered, increasing the cost, and specifically we're doing that for Medicare patients. So I was also part of that. Decided I wanted to go back to school again. I'd always been itching to learn more about finance. I learned a lot about quality improvement and the clinical side, but didn't have as much experience in the finance side. And that's really important if you're thinking about how to deliver this care efficiently. And so ended up going to Johns Hopkins to get my MBA. And then in the middle of that, COVID hit, and did a lot of great things with COVID. Of course, like every other clinician and administrator was running around and trying new things and having to implement things very quickly, which was great. But at the same time, I thought, okay, I need to figure out what my next step is. Do I want to stay in this QI space or do I want to expand? And when I started thinking about like adding the finance piece of my work, I thought my next step should be a chief medical officer. And that was good because of the finance piece, but also because I did not have as much experience in the hospital administration setting. Most of my administrative experience have been in the ambulatory setting. Of course, clinically, I'd spent a lot of time in the hospital, but not administratively. And so looked around, found a small hospital in North Carolina that was affiliated with UNC, and decided to make the big leap, which I never thought I would do. I come down to North Carolina and work at this hospital. And it was, again, a great experience. I was their first chief medical officer. They had some opportunities in the quality space. So it was good that I was able to apply a lot of that there. And again, it was full circle. This was a hospital of last resort. It was the only only community hospital in the county. And the patients that went there were often underserved patients. We had probably at least 40% Medicaid penetration with a large number of uninsured patients as well. I had a unique experience because I was an administrator at the hospital, but I also worked clinically as a hospitalist. So I'm seeing the patients that we're taking care of. And what I always told people once I was there for a few months is I used to talk about the lack of social services in Philadelphia. But when I went to Eastern North Carolina, I said, oh my God, Philadelphia's social services were amazing in comparison. There was so many issues around lack of access, homelessness, and not the typical homelessness, like, the person who's begging for money on the street. Like literally, I can't afford to have an apartment, although I may actually have a job. So we have no place to send you. You sit in the hospital for 3 months, although you're perfectly stable to go. Behavioral health issues, which we've all seen explode, especially during the pandemic. Folks who, including children who sat in our ER, again, for weeks or months, waiting for services and waiting to be placed. So again, a very eye-opening experience, a very frustrating experience from that social service standpoint. And again, seeing how those environmental factors play such a huge role, oftentimes more so than the disease state itself, in really affecting the health outcomes and the care. And even beyond that, just the overall life experience for these patients. And so when I got the opportunity to become the Deputy Chief Health Officer for City Block, I thought I've come full circle. Like I've come full circle from, where I grew up, from thinking about sort of underserved populations, thinking about social service in college and medical school, thinking about it, at Temple, being at a hospital in North Carolina where this was an issue, and having the opportunity to be at a place that is focused on value-based healthcare, focused on doing it with a health equity lens, and has the money to sort of be innovative and progressive as well. So it's been a wonderful experience. I'm looking forward to what I'm able to do in this company. And I'm looking forward to also, again, I think looking beyond our traditional clinical levers to see how we can really push the boundaries of success for this population.
Wow. That's my first word. Wow. I'm usually not speechless, but I am in a good way, in an agreement way, and we have so much work to do, and you are the right person to be leading this charge in Metro Philadelphia. And I would even extend that to around the nation, the world, people who will watch this and see what the possibilities can be from the work that you've done and how you've been creative and navigating your career. And I just love how you've been your biggest advocate, and you've been very candid about what you want and where you're going. And okay, I think this is time for you to be a CMO. Like, I'm sitting there thinking, like, I want every little boy to hear what he just said. Like, do y'all hear the confidence? Like, I love it. I love it. You talked about a lot of things, and I feel like I want to jump all over the place with this, but houselessness. Let me go back to the social service thing. I experienced the same or very similar when I lived in Missouri. I thought, you're from your hometown. Y'all need to do better. We can do better. Why is it so slow? But I got to Missouri and I was like, so where's this? And they were like, oh, we don't have it. I'm like, what you mean you don't have it? It's like, right. It was definitely an eye-opener, and I realized how advanced, if you will, Philadelphia is, and how blessed we were to grow up in Philadelphia, because even now, living in Georgia, I'm still shocked at some of the things that I see and learn. So houselessness is really big here in Georgia, and I'm not surprised to hear about that in North Carolina, but with the transition back to Metro Philly, are you seeing that houselessness has increased, where people they work, but they just can't afford to live?
Yeah, so that's a really interesting thing. And I'll back that up for a second, and then I'll get to the homelessness piece. But one of the things I've learned, and I think this is the unique nature of my journey, which was not part of the plan necessarily, was how I was able to see the underserved in a large urban area and really make the connection to an underserved population in a quasi-rural area. And I would always hear people say that, like, oh, they're very much the same, and there are more similarities and differences. And I'm like, yeah, whatever. But you really see that. I will say access. So access is a problem. So if you are in North Philadelphia, access is a problem for healthcare. If you're in quasi-rural Eastern North Carolina, is a problem. But the difference is, physically in urban Philadelphia, you have 5 large academic health systems. So physically, you can get to those places. They're there. It's just a matter of whether or not they take your insurance, whether or not there are other barriers, transportation, things like that are stopping you. Whereas literally in North Carolina, it was the nearest place is an hour away. We don't have that specialty. You have to go 2 hours away to Durham, to UNC or Duke to get that specialist. And so I saw how access plays out in those different areas, but in sort of different ways, and there are different barriers to each one of those things. The homelessness issue, I would say in North Carolina and in Philadelphia are very similar. I think it's a lot of it has to do with pricing. And a lot of people have been priced out and there are not enough homes. I would say in North Carolina, what you're seeing, although in general, the pricing of the housing is less than you find in Philadelphia, but what you're seeing is they're just not building any housing. And so all of the housing is going really to people who are coming from other places. So you're having the COVID effect, right? So I'm coming from New York City. I have a lot more money to spend. So now I'm pricing out the people who have been there for generations, and now they can't afford the housing. And where else are they going to go? This still is the cheapest housing in the country. And so they can't move to Philadelphia or New York City because they can't afford that. And so it sort of exacerbates that problem. And in Philadelphia, you're sort of seeing a lot of that as well, where of course a lot of areas are gentrifying, places where people weren't living before are becoming more and more expensive. And how that manifests, and the thing I would tell politicians and policymakers about this, is that it affects everybody. Like it literally, what happens specifically in our hospital is that those people would take up beds. They would take up beds in the ER. They would take up beds in the hospital. And so if you come to our hospital, everything is now backed up. And so if you have an issue where you're actually acute issue where you should be in the hospital, now your services are affected because there are people there that are only there because they don't have a home. And then your ER wait is longer. And it could potentially lead to poor health outcomes for you if now the attention is focused on people who, again, should really be somewhere else, but they don't have the social services to support them in terms of things like their homelessness. So I don't think people recognize how all of those things trickle down and affect them. They're like, oh, that's nice if we, give people housing or make sure they have access to housing. And yeah, I could probably see that there is probably some connection to health outcomes. But I think what we can do is make it more clear that it actually affects the health outcomes of everybody when those folks aren't taken care of appropriately. And I can go down the line and say that with a lot of different things, including things like behavioral health. But I think having folks understand how it affects the overall functioning of the hospital is something I think we need to do a better job at.
You opened a can of worms with that one, because as you're talking, my mind is all over the map. Like you said, we can go down so many different paths with this behavioral health. But I was even thinking about going back to your Temple story with CHF and congestive heart failure, diabetes, anything that's dietary dependent, which is everything. But simple things like if I can't access the food I need to help me thrive, or if I have to choose between keeping a roof over my head or keeping the electricity on so that my food what food I do have doesn't spoil, and actually going out to buy healthier options, kind of going to lean to what America was built on, which is convenience, fast, cheap, salt, fat, sugar options. And I think you're right. Our policymakers have to do better. I said this in another podcast where our policymakers at the local level, at the national level, they're somebody's baby. How? Please tell me how your grandmama would feel about some of these decisions you're making about food and housing. I don't think they would be happy. I can't imagine any of them that would be happy about it, especially those that are still hanging in there who lived through what we call the roaring 20s and the depression and just everything after that. I'm pretty sure they would want what's best for the masses because, like you said, it's all connected. Just imagine Dr. Spencer, aka Steve. Okay, I call him Steve, y'all. Just imagine if, and maybe this was happening, what happened in North Carolina was happening in every other state prior to COVID hitting. And there was no capacity for COVID patients because you got patients in the hospital because they don't have anywhere to go. And it probably did affect some health systems like that, but just imagine if that reared its head during the peak of COVID. Like, yeah, it's embarrassing, but why aren't we doing anything about it?
Yeah, so I will say unequivocally, yes, it did play a role. So during the height of COVID, which to put this into perspective, so when COVID first hit in Philly, I was not working clinically in the hospital. I was mostly doing outpatient work and then of course doing my administrative work as well. And so I was not there on the front lines those first few weeks of COVID. And I sort of thought about it and I was like, oh, not that I wanted to see, death and morbidity and things like that, but I felt bad that I wasn't on the front lines clinically. And then I, got the CMO role almost a year later, started that and started working in the hospital. And I said to myself internally, I was like, oh, it's nice to be in a hospital. Again, I felt bad about not being on the front lines clinically in a hospital at the beginning of COVID. And I was like, that's over. Whatever, we're gonna do a great job in this hospital. And literally, it was that August, a few months after I started, that we had the Delta surge. And the Delta surge in North Carolina was, I would say, worse than the original COVID was, even in sort of the Philadelphia area. Certainly, it was worse than what they had seen in North Carolina. So the initial surge that they saw was bad, but not horrific. The Delta surge was unlike anything anyone had seen, and we were not prepared. So we literally at times had to divert cases from the ER because we were completely backed up. There were multiple folks who were admitted and were sitting in our ER for long periods of time. So that backed everything up. So again, you come in for a heart attack, heart failure, that can potentially affect your care because all these people are backed up. And yes, there were people on our floors who we couldn't get out because of social issues that they had that kept them in bed. So it creates this whole domino effect in that respect. So I would say yes, that happens. And yes, people are not clear about how these things all play a role. And one of the things, even when I did community outreach or I do any sort of foundational or fundraising work, I always try to get people to not think of it as a nicety. Like, oh, this makes me feel good, so I'm going to take part in this organization or give some money. But actually, almost selfishly, look at it as how does this problem being manifested and not taken care of affect me and my community? So I think that's the part that we unfortunately, people are selfish by nature. So unfortunately, we have to get people to see, how does this affect me by having these issues not well addressed? Specifically, I would say with food, and I think this is something that City Block does really, really well. So we have what we call an advanced care model. So, we have a primary care doctor, but we have all those wraparound services I talked about with behavioral health, pharmacy, and all those other things. But as part of that too, it's not that the providers at the center and sort of directing everything. We really want our processes to direct it. So we want, if you have CHF, you don't have to necessarily, and we know that it's already diagnosed. You don't have to go to the doctor who then says, okay, you have CHF. Let me see what pieces of this wraparound service you can go to. We know CHF, you need these 5 things. And other members of our care team can facilitate that care. So part of that, if you have CHF, will be, what do we do nutritionally? What are we putting forth as a nutritional treatment plan? Again, not a nicety, not your plan is really these 5 medications and seeing your cardiologist. And by the way, here's a sheet of paper on what you should eat. But really looking at that in the same respect that we do those 5 medications or that referral to the cardiologist. So it is actually a treatment plan. And the other thing that's great about how we do that is that maybe the first step is we say, hey, these are the foods you should be eating, but then we are going to wrap around a nutritionist into that. And we're also going to leverage tech. So we have partnerships with people who are specifically involved in the nutrition world who will do things like make sure you have an appropriate meal. Or the other thing that we're on the cusp of doing as well is going further and saying, okay, we have recommended what you should eat. We can recommend the meal. Now, can we get the meal to you? And putting all those services in place. And again, I may have said this, and I think I did, but the way the company thinks is, how do we recreate what someone with means and with commercial insurance may have access to? Because again, that's something that someone with commercial insurance, they could have access to being able to create a meal plan, buying their own food or having someone create it or having someone bring it to them. But how do we recreate that in the Medicaid space for people who don't have the means? But we know this will directly affect their healthcare and their health outcomes in these specific disease states. So I think that's where we need to go. Again, is when we're creating these programs and specifically using the use case of nutrition, that it's not a nicety, it's not an add-on. This is an integral part of the care plan for these patients.
Absolutely. And you thank you for segueing there, because that was going to be my next thing about, oh, you're doing some phenomenal work at City Block. And since we're on this topic of social services and how the ripple effect is massive at a population level, and getting people to see how your individual behavior, if you will, impacts everybody. I'm glad you transitioned there, because we've known this for over 80 years. That we can, if we catch it before it gets, too terminal, we know that we can reverse atherosclerosis, heart diseases that are not genetically, that don't have genetic predispositions, if you will. We can reverse diabetes. We can do a lot of things. And we know that, 80% of all of the top comorbidities are lifestyle related. And it's all interconnected, right? So I love how you said, we're going to do a nutritional plan, do an assessment. Here's what you need, but how do we get them the food? One question came to mind is, and I know you're working with the Medicare population, does City Block, or are you all thinking about giving the option of, for people who can, helping them learn how to cook the foods in a way that promotes health? So that way, maybe step 2 is they cook it, and step 1 is we teach them, and then we can now help the next set of people and get them started, and I don't know, each one teach one kind of thing. I know it's still fairly new, but that's what came to mind as you were sharing, because heart disease is near and dear to my heart. It's why I do what I do. I watched my grandmother's demise over probably 2 decades. I didn't understand it was heart disease. I just knew she was always, sick and nodding off sleep. Right. But being very intimate the last few years, I was like, there's no way I'm going out like that. And I want to help everybody else who looks like me not to go out like that. So, I applaud what you guys are doing, but I was curious how or if you guys are thinking about that. And then I'll tag on what I observed last weekend and see if you guys experienced that as well.
Yeah. So it's a few things I want to anchor on that you said. One is, I think we can certainly, I can certainly empathize with you watching your grandmother. So my parents are deceased, and they both died early in their early 60s. And they both died because a large part because of environmental factors. Both of them had diseases that were largely preventable, but clearly secondary to lifestyle choices, again, died way, way too early. The part about the teaching, you teach someone to cook and how do you do that? It actually reminded me, and I think I have a pretty good grasp of this now. It actually probably took me about 10 years to really get a good grasp. I had heard people talk about it all the time, but I was like, what is really the difference? So, I talked about we deliver healthcare with this health equity lens. And I would hear equality and I would hear equity. And some people have come up with these great schematics with the differences. And so when we think of equality, we are really thinking of, oh, I'm going to give everyone with congestive heart failure a piece of paper that says these are the foods you should be taking or eating, right? And some people will say, oh, these are the foods I can go right over to Whole Foods and get those foods now and cook them up, or maybe I'll have my personal chef cook them up for me. But then other people are like, this looks like it's going to be expensive. I can't afford this, or I don't have time to go there. I have to go to work, or maybe it's easier to just go to McDonald's, or go to the Chinese restaurant. And so that's where we get the equity part. So for those people, you have to give them a little extra boost, and we have to do a little bit more. And so that's when you can get into the ideas where you're saying, we need to actually teach you and make sure that you can actually cook these foods. We have to go out and get the foods for you, or help you to get the foods to bring them in, and to make it easy for you to do that and decrease those barriers. Or we may have to go so far as to bring you the actual meals, depending on your situation. So it's really an individual care plan based on what it's going to take to create equity for that particular patient. And I think, again, that's not something we have done well in the medical field. We have had plans where we think, well, I would say truthfully, it's only been recently that maybe we've even gotten into equality. We all know the history of the country in medicine where it wasn't equality. But I think, in the more recent past, we have at least gotten to the equality part where we're trying to give everyone the same level of health care. But we have not gotten to the equity part where we're really developing individual treatment plans for that patient who may need a little bit more help figuring out how to cook those foods, or to obtain those foods, or to actually get the foods brought to them. And I think that's the piece that we are trying to get to, is to say, hey, this is how you do it in an equitable way. And also, the hard part is going to be, we can do it at City Block with our members, right? But can we scale this and make sure that every Medicaid patient has access to this? And I'm just going to make one caveat too. We focus on Medicaid patients, but we also have duals. So we have patients that have Medicaid and Medicare. So we have almost all of our patients are Medicaid, but we do have some Medicaid patients as well.
Oh, thank you for that, because I said Medicare earlier. Sorry about that. Medicaid. No, that's good. So this is population health at an individual level. And my tagline for my company is, take your health back one meal at a time by eating more plants. That's how we help the population. It's really one patient at a time. It's always ever been that, one community member at a time, one human being at a time, whether you have more melanin in your skin or not. And I love that some may be ready and able to cook the food and do the shopping, and some not so much. And that's okay. We're here to serve them. I love what City Block is doing, and I'm glad that you're leading the charge, because this is a model, as I alluded to earlier, that so many other companies can get on board and get behind to help. If we really do want to say what we want to do, which is reduce the burden of healthcare disparities and disease in this country, and to reduce the GDP around healthcare, we can do it. We have the resources to do it too. That's the other thing. I just would love to see more companies really take it seriously and do the work. And I'm so grateful that you all are taking the charge to do it. And I'm excited to see what comes out of it, the data, but more importantly, the lives that are going to be changed. Because guess what? You're helping Medicaid patients. Many Medicaid patients spend a lot of time with their grandbabies. And so this is almost their first dose or their first lesson in nutrition, is Grandmama's sick because she was eating this, but now she's eating this. Oh, let me eat more fruits and vegetables because I want to be healthy like grandma or grandpa or auntie or whatever it is. So, or maybe not even that old. Maybe Medicaid is 25, maybe Medicaid is 30. Everybody's circumstances are different. So there's even that component of it that I love, at least that I hear in my mind coming out of the work that you're doing. And I'm just so grateful for that work. And, you know, we can go on for hours talking about nutrition and all the positive benefits that it brings, not just to heart disease, but, you know, people say, well, what can I eat for heart disease? What can I eat for diabetes? What? I said, listen, the answer is the same. It's always going to be plants, plants, plants. Cooking without oil, things like that, or limited oil.
The thing I would say too that I just wanted to put out there, a couple of things. One is certainly your diet is connected to heart disease, and that's pretty clear. Hypertension, diabetes. I would say diabetes by far. You know, we know clearly obesity is very much connected to type 2 diabetes. But the part that I don't think gets as much attention is cancer. So if you look at almost any type of cancer, the number one risk factor, or at least in the top 5, is obesity. And so, you know, there have been a lot of studies also looking at specific foods, you know, red meat and colon cancer and things like that. But even beyond those specific things, breast cancer, your risk for breast cancer goes up tremendously if you are obese. Your risk for colon cancer goes up if you're obese. So I think one of the areas I would like to see people focus a little bit more on is the association with obesity and cancer risk, because I think that's really important. The other thing you sort of touched on is how you utilize these healthcare interventions to really have a wider effect on the communities. And I wanted to touch on, you know, certainly we can use nutrition as a use case. But the other thing we're doing, again, looking at this health equity lens, is trauma, which I'm obsessed with now. You can define that in a lot of different ways, but I think there are 2 big things that I'm thinking about when I mention trauma. One is, I think the COVID pandemic itself and sort of the isolation specifically, I think was a traumatic experience. Certainly the deaths associated with COVID and family members dying, and just not knowing, you know, what to expect and what's going on was traumatic. And I think we're seeing the ramifications of that in increased substance abuse and behavioral health issues. And then it leads me to my other piece of that trauma, which is violence. And especially when you're dealing with underserved, marginalized communities. And what does that mean to our young people specifically when they're repeatedly seeing violence in their communities, when they feel unsafe in places where they did feel safe, like schools. I'm really obsessed with that. So we're looking at trauma-directed care. So really focusing on trauma and using that again to drive health outcomes. But again, I think that's one of those multiplier pieces where we really need to treat our community in terms of trauma and how that affects everything. And again, if you're traumatized, are you going to make the right decisions about what food you should be eating? Or are you going to go to the gym? Or right? Are you going to make the right lifestyle choices that will affect your health? So I think all of these play a role, and maybe they should be less siloed. So as we're talking about what do we do about gun violence in the city of Philadelphia, we're certainly not just talking about policing, but we're not also talking about looking at programs specifically to reduce violence, but those programs should have overlap with health programs that are looking at trauma-directed care and really using that synergy to really drive a community outcome.
Absolutely, and that's the beautiful thing. You're right. We're very reductionistic. We have a very reductionistic approach in this country to healthcare, and it's very siloed unnecessarily. I mean, I get it, you know, but you're right. I agree that we need to look at all of it because, you know, it's so simple to hand somebody a piece of paper and say, here's what you should eat. But really, we're not even tackling people knowing what to eat. People know what to eat to be healthy. That is not an issue. Okay, even in underfunded schools, we are talking about fruits and vegetables, beans and rice, drinking plenty of water. it's really the psychology and all the other environmental factors that go into eating that's leading to that decision. Like you said, if I'm traumatized about X or Y, I am not walking in the kitchen to cook some steamed kale with carrots on top and a little bit of garlic brine. Like, no one's, I'm gonna say it this way, the average person is not thinking that.
Right.
And, how do we get people to learn how to do life in a way where it's balanced enough in the moment that you can still make reasonable decisions for tomorrow, right? And I think that's really important. Thank you for bringing up cancer. I bit my tongue on that one a little bit when I was giving examples, because for some people it's a very sensitive topic. And the oncology community is very guarded about when people discuss root cause, because in their mind, it's very genetic based, it's very environmental. And when they think environmental, it's like the air, the water, the pollutants, and all that's fair. It's definitely legitimate. But when you look at the root cause, and I want to say I pulled this infographic from CDC, cancer, diabetes, heart disease, stroke, and I'm probably drawing a blank on a few others. The root cause of all of that went back to food. Went back to nutrition. And that's a loaded conversation I probably need to do later on this year around cancer and what we eat. And I'll say it shortly in this way, is the China Study Project done by T. Colin Campbell. It's pretty well known, at least in the medical community. But he was out studying protein, for children who needed to eat over there in China, basically. And he was there for a couple decades, I think. Short version of the story is, they were trying to find ways to feed privileged children, but they realized that, or let me just say people, because I don't know if they were all children, but they realized that these high protein meals were leading to liver cancer. So we confirm, animal meat, animal diets actually upregulate things that should not be upregulated, which is a nice way to say it, and it downregulates the things that should be regulating cell growth. So now you got apoptosis not happening, that's downregulated, which is basically cell death. And you got the upregulation of the cells just dividing. And there's so much evidence-based research that demonstrates there's still a point of return if we change our diet and start eating foods that basically obliterates that overregulated process. And I'm speaking in very, very, very general terms here. But then there's also a point of no return. And unfortunately, and that's with a lot of diseases. Once you get there, you can probably balance quality of life, but it's going to be very difficult to really get back to baseline where you don't have a terminal illness. So what are we saying here today? We can own our own health. We can take it back. We have people like you that are out there on the ground in many respects. And again, I love what City Block is doing. When I'm in Philly, I'm going to see if I can come visit y'all. But
So just that, so we are not in Philly yet. So I'll give you our markets. I'll be in Philly, but we're in Ohio, Indiana, North Carolina, New York, and Massachusetts currently, but coming to other places.
I'm putting y'all on a map too soon. Okay, sorry, City Block CEO and all. I'm just putting y'all on a map. Okay. No, I appreciate that though. Oh man, so I'll have to come where you guys are to see it. I don't care where it is.
Yeah, it's a great place.
Yeah, but this, like I said, this conversation, you and I, we could talk about this for hours. We could definitely set up a whole workshop, symposium, and really just go deep and really look at the analytics behind this, the strategy that you're putting in place, and you just talked on all these different markets, but we're not going to open that can of worms. But that's exciting. And guys, I think the takeaway is, guys and gals, everybody who's listening, is it can be done. So you have people like me who are out there cheering you on, giving you practical information, trying to make it digestible, get it out of the lab, get it out of the manuscripts, and get it in front of you in ways that you can understand. And then you have this, I'm calling him the population health medical guru, because that's who he is to me, Dr. Steve Spencer, who's literally out there putting strategy behind this, dealing with Medicaid, like trying to make these policy changes. So we applaud you. Thank you so much for your service. Thank you for what you did, obviously pre-COVID, but during COVID, supporting families and loved ones. And thank you for what you're doing now for the health in lots of different markets that are going to benefit from having a nutrition plan, an actual plan, and not just on paper, but an actionable plan that is supported with social service resources in the various communities. Thank you so much for what you're doing. And thank you for coming in my kitchen today to talk about all things health and wellness. Thank you so much. I'd love to have you back whenever you have time, but thank you. Thank you so much, Dr. Spencer.
It was my pleasure. Thank you so much for having me.
You're welcome. Well, this is In the Kitchen with the Plant Based Nutritionista. Thank you so much for joining us. If you want to learn more about Dr. Spencer or City Block, you can look at the details below. His whole bio will be there. The link to City Block will be there. All the great work that they're doing will be there. And if you are an organization who wants to partner with them and get on this bandwagon, please reach out to City Block or Dr. Spencer directly. Have an amazing day.